Well, whenever we monitor a high-risk pregnancy, we have to ask ourselves what is the consequence of monitoring and what is the consequence of management. And we have a battery of tests, Doppler, CTG, and biophysical profile and whatever, but which test will tell us when to take the baby out? And is there at all a single test or a combination of tests which will tell us when to take the baby out? And we are talking about the small fetus, which is small from starvation. This is the one we're interested in. This is intrauterine growth restriction. We are not talking about the normal small baby. I mean, this is important to have a high negative predictive value to sort out normality from high risk. But what we want to detect is the small fetus due to high placental resistance, due to starvation and placental insufficiency. Now, how should we monitor? We all agree that we should perform CTG. We do arterial Dopplers, venous Dopplers. In the States, they do a lot of biophysical profile, and you know there is a biophysical profile score. I mean, we don't really use a score in Europe, but we do the biophysical profile because while we are doing ultrasound, and while we are doing Doppler, we assess a score. We just don't count the numbers together. And the big question is when to deliver. And why do we have to ask ourselves when to deliver, or why is that a problem and an issue in IUGR? First of all, these are the survival and mortality rates corresponding to gestational age, and this was not a population with small children. This was a population with normally grown children. A population with preterm rupture of the membranes. Now, if you are an optimist, you look at the blue curve. This is the survival. And if you are a pessimist, you look at the red one. This is mortality. And of course, there's a mirror image of both. And you can see that there is a steep increase in survival up to 32 weeks. And the 50-50 chance of 50-50 crossover for survival and mortality is around 24 weeks. Now, later during this talk, we will also look at a population of severely IUGR fetuses, and you will see that the 50-50 crossover is later than 24 weeks. But it's not just survival, it is morbidity which counts. And parents will ask you, what is the chance that my baby will be healthy if it survives? And this is a very important issue for the future of the family and for the society at all. Now, here you can see the death rates, which all decrease with advancing gestational age. For low-risk pregnancies, that are the filled circles, it's the lowest curve, and they have the lowest death rates, of course. Those with placental abruption, these are the open circles, are quite stable over gestational age because placental abruption at 36 weeks is an emergency situation, and it's almost the same as at 28 or 30 weeks. Whereas the small for gestational age birth are the one with asterisks, run quite in parallel with a low-risk gestation, but always higher up. So at any given gestational age, the death rate for an IUGR baby is higher than for a normally grown baby. These are the curves for respiratory distress syndrome, sepsis, intraventricular hemorrhage, necrotizing enterocolitis, retinopathy of prematurity, and bronchopulmonary dysplasia. And you can see there's a steep decrease in all these different kinds of morbidities up to 32 weeks. And after 34 weeks, we don't really have to worry about this kind of morbidity anymore. That's at least what we thought up to a recent publication. I'll go back to the other slide in a minute. That there is also increased risk of adverse neurological development for late preterm infants, as you can see here, between 31 and 36 weeks. There is still an increased risk for cerebral palsy and developmental delay. So gestational age plays an important role, not just in morbidity, in neonatal mortality, but also morbidity. And if I go back to the previous slide, here you can see different risk factors for newborn encephalopathy. The ones in dark red are preconception, the blue ones intrapartum, and the orange ones antepartum. And you can see at the very bottom that intrauterine growth restriction below the 3rd percentile is by far the highest risk factor for newborn encephalopathy. It's about 38%. It's a myth that respiratory distress is less frequent in babies with SGA as compared to AGA. And it was a myth which was long perpetuated in the literature that these babies are better off because they are trained in utero for a stress situation. If you look at this paper and these data, you can see that at any given gestational age, the risk for respiratory distress syndrome in SGA babies, these are the open bars, as compared to the closed bars of the AGA babies, is significantly higher than for normally grown babies. And this is even true up to 35, 36 weeks of gestation. So this tells us that on the one hand, small babies are at a significantly higher risk for mortality and morbidity. On the other hand, gestational age is still an important factor, advanced gestational age, and to reach a higher gestational age is still an important factor and aim to improve outcome in these babies. What we have to do is to balance the intrauterine risks of the hostile intrauterine environment versus the postnatal risk due to severe prematurity. Now, if we look at the CTG, nowadays we do have parameters and variables available which we can measure and for which normal ranges exist. So the time for just eyeballing the CTG should be passed, and we should look at the normal ranges for short-term variation. You can see here short-term variation expressed in milliseconds. Is the millisecond the beat-to-beat time between the heartbeats? It's an average measurement, of course. Increases with advancing gestational age. As you can see here, there's a normal range available for short-term variation. And we also know that if short-term variation falls below a threshold value of 3 milliseconds, there's an increased risk for fetal acidemia and intrauterine death, and this is due to the data provided by Dawes and Redman. And you can see here that if short-term variation is above 3 milliseconds, the risk for metabolic acidemia expressed as a pH below 7.12 and the base deficit of more than 12 millimole is quite low. It's about 3%, and there were no intrauterine fetal death. Whereas if it fell to 2.6 to 3, there was an increase of metabolic acidemia and IUD, and even higher below 2.6 milliseconds. So this is something which is an objective measurement. It can only be done by a computer system. You cannot measure it by just eyeballing it. But now we have reference ranges. We know that it's dependent on gestational age, and this is something which is reproducible and measurable. And we should use it. I mean, whatever we do in ultrasound, we do measurements and we have reference ranges for biometry, for all the Doppler variables. So why not for the CTG? And what we can see here, that we have to use each fetus as its own control. So to a certain degree, this fetus is already an individual person that shows us that it has a sort of kind of baseline short-term variation, because if you look at the longitudinal measurements in normal fetuses, you can see that they don't behave like Torvit has shown for the ductus venosus. PIV, for instance, the short-term variation is quite stable, and if they are on the upper range of normality, they stay there. If they are at the lower range of normality, they stay there as well. So we should use each fetus as its own control in longitudinal monitoring, and this is something to do with conditioning as well. Now, we know that the application of betamethasone for the introduction of lung maturity has an effect on the short-term variation. There is a decrease in the short-term variation after 2 days after the initial application of betamethasone, and we have to take that into account. Now let's go to the Doppler monitoring and the different tools and vessels we have in assessing the fetal situation. Now, umbilical artery Doppler tells us very well whether the baby is small due to an increased placental resistance or whether it's a normal small baby with a normal placental resistance. You can see here the different blood flow classes with positive flow in the umbilical artery up at the top, then increased placental resistance, but still positive flow during diastole, zero flow and reversal of flow in the umbilical artery. And we know from the Cochrane database, and that has been shown already in the year 2002. I've not changed this slide anymore because it has been shown 10 years ago, almost 10 years ago already, that umbilical artery Doppler, on the basis of evidence-based medicine, can reduce perinatal mortality. You can see on top of this graph all the different kinds of perinatal mortality are decreased significantly by looking at the umbilical artery Doppler in a high-risk population. Of course, this can only be achieved by doing something after there is a severely abnormal umbilical artery Doppler. And what we do can be seen here. There is a significantly higher proportion of pregnancies delivered electively before 30 weeks of gestation, and we have a significantly lower incidence of cesarean sections for fetal distress. And this is what we want to achieve, of course. We want to get them earlier out to avoid emergency situation in the middle of the night or on the weekend, and to get them out in a better condition. And by looking at the umbilical artery, we can achieve this. Now, the umbilical artery Doppler is not a screening test. It has not been shown to have any positive effect if you apply it as a screening test in a normal population, but it is a very good test, and it is very helpful in management of a high-risk population. Now, what happens if there is umbilical artery abnormality? If there is a high placental resistance, the baby reduces its growth, and it also reacts, it adapts its circulation. There's a redistribution of blood flow to the vital organs, which is the heart, for instance, the myocardium, the coronary arteries, the brain, and the adrenal glands. And you can see here the typical change in waveforms. This is a normal aortic waveform with not a lot of flow, but plenty, but still positive flow during diastole, whereas if the resistance increases in the periphery, there is a decrease or absence of diastolic velocities. And the opposite happens in the middle cerebral artery. This is normal, and this is abnormal, but it's a good adaptive response to high placental resistance. There is a decrease of resistance in the cerebral circulation with an increase of diastolic flow in the middle cerebral artery. And as a second step, usually as a second step, not in all the cases, but in the majority of cases, as a second step, if the preference of blood flow to the vital organs, which is also the myocardium, is not maintained in a sufficient way, or if it decompensates, there is cardiac decompensation, there's an increase in end diastolic ventricular pressure, and therefore we have a decrease of velocities during A wave, during atrial contraction on the venous side, and this is away from the ductus venosus, and this is what happens then in the most severe cases, a longitudinal observation in a small fetus. And at a certain point, we can see severely abnormal waveforms in the ductus venosus with zero flow or reversal of flow during atrial contraction. Now, you must not mistake the ductus venosus with any other venous vessel, like the inferior vena cava or like the hepatic vessels. And Torvid will talk about that in the afternoon as well. So, in the hepatic veins, for instance, which are a little bit higher up in the liver than the ductus venosus, you can see lower velocities. I mean, the pattern is the same, of course. This is systole, the maximum of flow towards the heart. This is early diastole, when the AV valves open, and this is atrial contraction, late diastole. But due to the fact that the velocities are lower in the hepatic veins, of course, all the velocities are nearer to the zero line. Therefore, we may well have zero flow or reversal of flow during atrial contraction in normal cases, in a normal situation, whereas this is never the case in the ductus venosus. The velocities are significantly higher. And you must not mistake a normal, for instance, middle hepatic vein waveform with an abnormal ductus venosus waveform. And you must be sure that whenever you look and identify the ductus venosus, that there is a connection between the inferior vena cava and it connects to the umbilical vein where it comes from, whereas hepatic veins come out somewhere from the liver tissue. Yeah? And the Doppler, the color signal starts somewhere in the liver tissue, and there is no connection to another vessel, of course. And as you can see here, abnormal venous waveforms, severely abnormal venous waveforms in the inferior vena cava. The inferior vena cava runs in parallel to the abdominal aorta, which is here, and then it turns towards the right atrium. And in severely abnormal waveforms, you have markedly reversed velocities during atrial contraction. If it would be like that, it would be normal. Here the ductus venosus, and there is always the connection between the ductus venosus and the umbilical vein, which is here. And this would be the middle hepatic artery, a little bit higher than the ductus venosus. And if you look at that one, it has a completely different waveform as compared to that one. Both are abnormal, of course, but you can see markedly lower velocities and even reverse flow between systole and early diastole. So make sure where you are. Anatomy is a very important point. Now, as I have said already, that the first step is abnormality in the placental resistance. This is the cause for the baby's growth restriction. As you can see here, this is already an old image, but it's still nice and a classical one, I would say. Sorry, go back. Zero flow in the umbilical artery, normal flow in the inferior vena cava and the ductus venosus. The next step would be arterial redistribution, as you can see here. Severe increase of diastolic flow in the middle cerebral artery, zero flow in the descending aorta, but still normal flow in the inferior vena cava. There's an increased pulsatility in the ductus venosus, but still positive, clearly positive velocities or positive towards the baby's heart antegrade flow throughout the cardiac cycle, even during atrial contraction. Now, in monitoring, regarding fetal monitoring in IUGR, we have to identify trends. Don't base your management or your decision on a single measurement. You will always have time, unless there is placental abruption or something like that, which is an emergency situation, but that's completely different. You will always have time enough to identify trends. And each fetus is used as its own control. And of course, in studies, we have to correlate it with neonatal outcome and long-term follow-up. Now, let's just go to a few studies which have been published already. You're all aware of the GRID study. Now, this was a randomized study, of course, without a management protocol. And this is very important. Inclusion into the GRID study was based on uncertainty. So that was the definition of inclusion into the study. Of course, there had to be a small baby and there had to be an increased placental resistance. But owing to all the other monitoring parameters like fetal Doppler, CTG, the obstetrician did not know whether to deliver the baby immediately or not. That was the basis for inclusion, uncertainty. And there was no management protocol. So they were randomized to an immediate delivery group and a delayed delivery group. Delayed delivery group meant that you had to wait until you were sure what to do. So a switch from uncertainty to certainty, whatever that is, certainty. And you see that happened in a median time interval of about 4 days. To 4 to 5 days, the obstetricians knew what to do. Then they knew they had to deliver the baby because there was deterioration in whatever parameter. Now, what happened is nothing in terms of perinatal mortality. As you would expect, I can prevent, or you can prevent any or all intrauterine fetal death if you just deliver. You perform a cesarean section within 24 hours or within the next hours when you see a small baby, and you will definitely prevent intrauterine death. But what happens, you will have a higher percentage of babies dying during the neonatal period because they are born severely premature. And that's what happened here. Overall, the perinatal mortality rate was 10% and 9%, and there were more neonatal deaths in the immediate delivery group as compared to the delayed delivery group, and vice versa. That's what we would expect. The disability follow-up, or the neurological follow-up, defining disability at 2 years of age for babies born very prematurely, between 24 and 30 weeks, seemed to be lower in the initial diagnosis of the GRID study, which was published in 2004. You can see here that cerebral palsy, vision impairment, hearing impairment, Griffith developmental quotient below 70 was higher, 16% in the immediately delivered group versus in the delayed group. It was only 6%. So there was an initial feeling that it would be better to wait based on these data. That was a different kind of analysis, similar, a higher rate with disability in the immediate group, in the very preterm born baby, as compared to the delayed group. However, just recently, in the January issue of the American Journal, the long-term outcome of the GRID study was published. And of 376 babies, 80% had a known outcome, which meant it was known whether they were dead or alive. And if alive, they were evaluated at the age between 6 and 13 years. No difference at all. If you look at death or severe disability, overall 14% and 17%, cognition, motor, behavioral score, all the same. So what they concluded, clinically significant differences between immediate and delayed delivery were not found. So that tells us if you are not sure what to do, and if you don't have a management protocol, it doesn't matter what you do. Whether you deliver immediately or wait for another 4 or 5 days, it's all the same. So what we need is management studies, where we randomize to different management protocols. Now, based on our observational studies, and David has already shown this slide, we could show that the ductus venosus PIV, so changes in the pulsatility of the ductus venosus and the short-term variation, are the variables which would tell us or give us the best information on the fetus, on the condition of the fetus. Whereas something like large middle cerebral artery, amniotic fluid volume stay stable for a long period of time, and they are abnormal already from very early on. Because, of course, increased placental resistance is the reason for intrauterine growth restriction. And arterial redistribution is one of the first signs of adaptation. Now, this study showed us that it's not a good idea to wait until both variables are abnormal. So if the fetus has an abnormally low short-term variation in combination with an abnormally high pulsatility in the ductus venosus, it's not good, because mortality is significantly higher, 39%, as compared to the cases where at least one or even both parameters were still normal. Mortality was only 7% then. However, despite the fact that it is a mirror image, the short-term variation goes down and the ductus venosus goes up, this is not true that both parameters go up and down in the same fetus. There are some fetuses which show a decrease in short-term variation before the ductus venosus goes up, and vice versa. And this is good, because otherwise we would only have to measure one variable if the other one would tell us the same. So they behave differently, and what we know now is that we should not wait until both parameters are abnormal. But it's still the question whether the ductus venosus pulsatility is better than, for instance, the short-term variation. In another study published in the same year in the White Journal, all these studies have been published in the White Journal by Bashat, similar results have been shown. The ductus venosus PI goes up just a few days before the need for delivery. And in another study by Italian group, Ferrazzi, it was similar. You see green is up there. That's what they call the early Doppler changes on the arterial side of the fetal circulation. Red are the ones on the venous side. interestingly, in this study, first of all, they were really brave because they waited for delivery until the short-term variation fell below 2.2 milliseconds. And that's really brave because we know that below 2.6, we have already a high incidence of metabolic acidemia and intrauterine death. But Italians are strong. Only 40% had an abnormal ductus venosus S/A ratio, and only 20% developed reverse flow during atrial contraction in the ductus venosus, despite the fact that the short-term variation was extremely low already. However, they found, as has been found in the other studies as well, that perinatal mortality was significantly higher, the red bar, if you were in this group with severely abnormal ductus venosus waveforms, as compared to the early Doppler changes in cases where there was only arterial redistribution and normal venous waveforms. So this is another study which we participated in with Ahmed Bashad, and it was a huge risk population of more than 600 IUGR cases before 33 weeks, and the data were collected in several centers of fetal medicine. The overall mortality was 21%, so you can see it was really a high-risk population, and the intact survival rate was 58%. As you can see here, the neonatal survival rate of 50% was achieved at the end of 25 weeks. If you remember, the first study I showed you for a normal population in terms of size and not SGR, but with preterm rupture of the membranes, it was completed 24 weeks. So here we found out 25 weeks, 50% chance of survival. Up to completed 27 weeks, there was a 2% increase in survival rate per day in utero. And between completed 27 and 32 weeks, there was another 1% increase in survival per day in utero. But now the important question is, what about intact survival? And you can see here, intact survival is, as expected, lower than survival for any given gestational age. And the 50% intact survival rate has been achieved with completed 27 weeks, so 2 weeks later. And this is how we, at the moment, I think this is the best data which are available at the moment to counsel patients in a setting of severe IUGR and prematurity. With completed 25 weeks, there's a 50% chance of survival. With completed 27 weeks, a 50% chance of of healthy, intact survival. But individually, that's not very helpful, of course, because the parents will ask you, but where is my baby going to be? And then, of course, you have to look at the different parameters. And then we are where we have been before, short-term variation and ductus venosus. Now, neonatal mortality was higher at any given gestational age if the ductus venosus waveform was severely abnormal. Zero flow or reversal of flow during atrial contraction as compared to positive flow during atrial contraction. And the same was true for intact survival at any given gestational age. Intact survival was significantly higher in normal or positive waveforms during atrial contraction, positive flow during atrial contraction in the ductus venosus as compared to severely abnormal waveforms in the ductus venosus. So there are two important parameters which seem to play a key role. One is venous waveforms, the ductus venosus waveform. Second, gestational age at delivery. So this is the sequence of events. You have seen many different modifications of this slide already during many lectures, I'm sure. The sequence of events in the deteriorating intrauterine growth-restricted fetus, in Doppler waveforms, the heart, biophysical profile, and acid-base status. Now, I'm going to present you the latest results of the truffle study. And Christoph is going to get a heart attack immediately because I'm not allowed to present any results so far, of course. I'm not going to present any results, but I'm going to present you the design of the truffle study. And the good news is that it has been finished now. Recruitment has been finished. And so you will can expect the short-term results on perinatal data within the next 1 or 2 years. What do I have to do now? Okay, fine. So the important thing with the truffle study was that there was a management protocol, first of all. Second, the primary outcome was long-term neurodevelopmental outcome at 2 years of age. Now, the protocol has been published on the Lancet website for randomized controlled trials. Data have been entered via an internet-based database. IUGR was defined as abdominal circumference below the 10th centile. As an entry criteria, of course, there had to be an abnormal umbilical artery Doppler velocimetry because we wanted to look at small for gestational age or intrauterine growth restricted fetus due to increased placental resistance. There had to be viability. It doesn't make sense to have a management study on non-viable fetus, so estimated fetal weight had to be above 500 grams and gestational age at enrollment between 26 and 32 weeks of gestation. And of course, the variables we wanted to look at and to investigate had to be normal at the time of randomization. And it had to be singleton pregnancy and informed consent, of course. So what we wanted to compare is, the first question was, does the ductus venosus really help us? Or should we just rely on computerized CTG analysis? And if we use the ductus venosus, should we deliver on the basis of early changes, so an increased PIV, but still normal, still forward flow during atrial contraction, or should we wait until late abnormalities in the ductus venosus? Therefore, in the CTG group, if they were randomized to the CTG group, investigation of the ductus venosus was not allowed. It was forbidden. You could look at the middle cerebral artery if you want, and umbilical artery, of course, but not at the ductus venosus. The criteria for delivery were dependent on gestational age because we know that there's an increase of short-term variation with advancing gestational age. So it was a short-term variation of less than 3.5 milliseconds between 26 and 29 weeks and less than 4 milliseconds between 29 and 32 weeks. Early ductus venosus changes, as I've said before, was in PIV above the 95th centile, but positive flow during atrial contraction, and then the severely abnormal ductus venosus waveforms. And for all 3 groups, there was a safety net. Of course, for the first one, you don't need one because you would deliver on the basis of CTG anyway. But for the ductus venosus waveform, there was a safety net because we would not wait until the short-term variation would fall below 2.6 or 3 milliseconds, still in the presence of a normal ductus venosus waveform. And if absence of end-diastolic velocities were present in the umbilical artery after 32 weeks, in some of the centers it was possible to go back to 32 weeks for that decision, and reverse flow in the umbilical artery between 30 or 32 weeks or after 32 weeks definitely should the baby should be delivered. That was the safety net. There was a quality assurance regarding the assessment of ductus venosus waveforms and, of course, for the Bailey score, for assessment of the Bailey score. So all the pediatricians had to be trained in how to assess the Bailey scores to get a standardization for the tests. And this was the status. This was the status up to April 2010. So, and randomization has been finished in the meantime. And I haven't got the latest slide from Christoph, but I'm sure he will show it sometimes. Recruitment had ended now in January 2010. And at the moment, we are analyzing the data on the perinatal data, so the short-term outcome, which is not the primary outcome, of course. So we have to wait another 2 years for the primary outcome, and then for the analysis and writing of the paper, of course. So, but this study at least will show us whether the ductus venosus is helpful and whether we should wait for late changes in the ductus venosus or deliver on the basis of early changes. And by the time we will know that, I'm sure people will come and say, well, now you have to look at the aortic isthmus, or now you have to look at this or that vessels, I don't know where in the periphery of the fetus, or we have additional highly sophisticated tests, so we will have more randomized studies coming up. But we're all looking forward into the future and looking forward to the outcome of the truffle study. Thank you very much for your attention.